Happy Friday, Dr. Richards.
Happy Friday, Dr. Leib. How you doing?
Doing well. Just got to the Poconos here for Father's Day weekend, so hoping
Nice.
do a little fishing tomorrow, just and then see what the kids want to do for me.
Are you a big fisherman?
No, but I'm starting to enjoy it, but like I don't know what I'm doing at all. My father-in-law does quite a bit, so I'm his apprentice right now, and not a very good
Okay.
one, but getting better. And my son seems to really like it. So and here like there's lake fishing, so it's not too complex, but I enjoy going and watching him do his thing, and then I'm still learning quite a bit.
I think I've been fishing like twice in my whole life, and the biggest thing I caught was probably like essentially a minnow. Like it was probably
Yeah.
3 inches long. Had to put it back. That that's my experience with it so far. But I could use a good corrective experience of that.
Yeah. Yeah. So I get plenty of opportunities now. So hopefully year after year, I'll get a little bit better.
Nice. Have you been golfing at all?
I actually golfed last week at a scramble. It was like a high school reunion for the basketball alumni. So I got a little bit of the itch again to go back out. We'll have to go back out and start golfing again because scramble's great. It was
I'm in.
low pressure. The swing felt pretty good, but it's hard to hit them straight. Let's put it that way. But like it felt I didn't have too many just atrocious shots like you've seen me have before. So I felt like all right, now I got a little momentum.
I gotta get out. I gotta get out there. I haven't touched a club since I think we last played like last summer or fall. So
This is sort of
it'll be a rough one. Yeah.
yeah, that's good. Yeah, we're on par there, so we're perfect playing partners. All right, so today we're going to talk about pressure therapy, which is the terminology that we like to use for things like foam rolling, using different type of self-massage tools. Real popular now is the massage guns. You got the foam roll. You got all different types of implements to create pressure to the body. So because there's so many different implements, I thought, what is the broad term that what are we doing with all those implements? We're really just trying to bring pressure to the body, and we're trying to do it in a therapeutic way. So we'll talk a little bit more specifically about how we can think about that terminology and how and why what really is therapy, like what in the term therapy, and like why do we how could we use this pressure to create a therapeutic process. But generally when we're using that term for this podcast, that's what we're referring to, the things that people would know as foam rolling, massage ball, self-massage techniques. So I figured we'd start off with each other's experience that we've had over the years with this type of work. I know my experience, it started pretty much with my movement practice. A lot of it was through CrossFit, and I started using it more on myself than in really doing much with clients first. But then it slowly started to lead into my clinical use, and I started using it more and more with clients. As an athlete, when did you start doing anything along the lines of foam rolling, or when did it become in your consciousness, and how has it evolved for you over the years?
I remember in high school, I guess that was kind of that was like my first, or late middle school, early high school was my first exposure to the weight room. And I remember our high school strength coach had not foam rollers, but like the cut up like fat PVC pipes that were
Nice.
like six
Yeah.
inches in diameter. And that was kind of my first experience with it. And I mean, talk about like pressure.
Yeah.
That was a rough intro to it, but yeah, we didn't talk a whole lot much about like what it did, other than just I'm a high school kid who's like full of testosterone. It's like this thing hurts, so maybe this makes me tougher, or like for whatever reason, if I can endure this pain, something good is going to come out of it. That was kind of my introduction to it. And then I think honestly in college I kind of flip-flopped and like didn't touch it, didn't do anything with it. It was kind of like, from what I was learning or kind of looking at, I was like, all right, that doesn't do anything for me.
Mm-hmm.
and was very much on that train, like refused to do it for probably years on end. Um, and I mean, I think I've kind of landed now as like a rehab professional somewhere in the middle. Like I think it for sure has merit as in the ways, especially that I've seen you use it. That's kind of where I think I got a better understanding of what's going on potentially, and not necessarily that scar tissue is being broken up or something along those lines is happening, but just that we're changing, potentially a neurological response at the level of the tissues, and that can yield some relief or change some things for a, temporary, for the most part, amount of time, at least like after one session of it. So, now I think I use it more with people in some specific scenarios, but it's not necessarily something I start with off the bat with them, unless for some reason, I think in sort of the ways I've seen you use it, like where people might be kind of flared up, there's not a whole lot you can do with them, or it just seems like everything is on high alert, like mind is going a million miles a minute. It's a good way to kind of slow things down for people and bring them back to the sensations that are happening in their body right now. But yeah, I completely went from being, this is something I need to do every day in high school, and that this is gonna make me a better player or whatever, or strong, not, I guess not stronger, but I kind of thought that way. To being like, this does nothing. And now actually kind of settling somewhere in the middle. Thanks to exposure to people like yourself. But yeah, that's kind of my roundabout way of getting to where I am now. What about you? I know you probably were exposed to it at least earlier in time when it like became quote unquote a thing compared to what I was.
Yeah, I don't know about that. My experience is similar. I think I probably came about it later in my life. Like, so
Yeah.
I was a recreational athlete in the CrossFit world, and maybe a little bit before that, but it was brought to my attention, and I started using it. And I think one of the things that you alluded to that draws people to it and continues to is that there is a quick change that you're able to experience. It's pretty obvious. Like if you go after certain areas, as long as you have some type of movement to assess afterwards. And I think for me, that was something that CrossFit was doing on a regular basis. Like I had all these movements that I sucked at, I was trying to get better at, and my mobility just wasn't there. But I was like really working towards like getting a better squat so I can catch a clean or catch a snatch. And I could feel a restriction maybe in my hip or in my knee. So I would just bring a foam roller to my thigh, and then I would retest my squat and be like, oh, it feels better, it feels looser. So there was this, obvious benefit. And I think that's something that like stayed with me even as I started rethinking some of the theories that were out there, or just appreciating some of the evidence that, what people were claiming wasn't true. So, for me, I kind of went through a similar experience where like everything was some version of foam rolling or pressure work to try to make an adjustment or make a change right before you got someone back into a broader movement. But then I started to like back off a little bit because I saw some of the research was saying, like this isn't going to bring lasting change. But as like I always had that in my head that I know it's useful. Like it makes change. We just have to maybe have a better way of describing the methods, or not get lost in the structural theories of what's going on. And I think that even speaks to like that as physical therapists, we do a lot with manual therapy. We learn a lot about manual therapy. I would say that was a huge part of my orthopedic education was, what we do with our hands, how do we, move joints with our hands, and then also the theory around like what are we trying to do when we're manipulating people's joints with our hands. And I think like what you see in the research is like there isn't a really good consensus of any specific structural method or model, right? It's many things that are happening, and the theories are always evolving, to the point where I think there's more of a consensus that it's always multifactorial. Like we're treating multiple tissues at once all the time, and just touch will have a psychological change on people. So I think the same thing kind of occurs with when we bring pressure to our own body, right? Like, why wouldn't it? So it's a similar process of like appreciating that you don't throw the baby out with the bathwater. You just might have to develop your own reasoning for why you're doing the thing, as long as it's not isolated. It's not the only thing you do, and you're telling someone like all you got to do is this and you'll be good. No, it's part of a broader practice of movement. But if it does help someone move better, even temporarily, well, you may have given someone a window to, do the thing that they want to do better, and then that builds over time and gives them more confidence to improve that task. So, I think in a similar way, like I've definitely was doing way more of it early on and didn't really have a good grasp of why. And I think that the major difference, like in my early experience, was that I was all about creating as much pain as I could to the tissue. Like I felt like that was part of the practice. Like that was what I was shooting for, is like the more discomfort I feel during the massage, the more I could tolerate, the better it's going to be for my body in some way. So that I've definitely changed my tune on and my thought process on, especially working with clients and everybody, understanding that everybody has a different tolerance to everything, but especially pressure. And you could definitely like make people worse by having that mentality. So as a clinician, I needed more of a graded approach and a graded model. So I've certainly gone that way of late.
I can like vividly remember and still hear the voices of like my teammates in high school, and we'd get in the weight room and we'd get down on these PVC rollers, and everyone's like in agony, just like yelling.
Yeah.
Which I mean, I just it's an interesting memory.
Yeah.
I think at some point we ended up like hitting each other with the things because we were like, well, we're just building up tolerance to things.
Yeah.
But that's but I've seen you use pressure therapy in a lot of different ways. Kind of different than what I learned about in school and what I've actually just seen in practice. What are some of the ways you use it? I know you use a lot on the abdomen, for example, and tie in some different types of breathing techniques and position holds, but what are some of the guiding principles and some of the movements you'll tend to use it with? And if there's anything specific, like are there any specific movement restrictions you tend to kind of resort to using pressure therapy for more quickly than you might for other things?
Yeah, I mean, the model I've kind of come up with in my own head, and I've written about this in a couple of blogs, and I put it in my last book, is I tend to go through 4 different Ds in a sequence. So the first D would be like you have to allow yourself or allow your client to desensitize to the pressure. And I think that's the thing that like really just gets blown through, where like people don't take that into account. Like you were saying, it's like it's almost, if you're in certain communities, it's you should be like screaming in pain, and that's the more therapeutic process. Where what I've seen is like that can have a temporary effect for some people, that like, okay, that is the mentality, that it's almost an adrenaline response because it hurts so bad that afterwards you'll feel a little bit better there. But what we're missing is that we have, if we're thinking about this from an actual mobility perspective, to connect to what we talked about last week, we're actually trying to create a motion from like the outside, like superficial to deep in the body with the pressure that we're using, right? So in order to do that, we have to think like we actually have to get less sensitive to the pressure. So we don't want it to hurt as much as possible. We want to be able to tolerate more pressure, more depth of pressure over time, right? So that's something that's definitely changed in my mentality, because depending on the tissue I'm trying to work on, the anatomy might be quite deep that we have to get to. And if somebody is guarded and they're too sensitive to that pressure to allow the pressure to sink in, then we're not doing what we're intending to do, right? Like it'll be in that general area, but there'll be so much guarding to push that pressure out of you that we're definitely not getting any depth of pressure. So like I'm starting from that premise of like my intention is to get more depth of pressure, but in order to do that, I have to have somebody desensitize, or I have to desensitize to that pressure myself. So desensitization and depth of pressure or deepening of pressure kind of go hand in hand there. But the desensitization piece is so key. So that speaks to just sort of how the nervous system responds to stimulus in general. So we can think of it from a quick little structural discussion about just different entities in the nervous system. We have several receptors that, basically when the body senses touch, there's mechanoreceptors, which basically will respond to different types of pressure. So they might respond to vibration, they might respond to a deep pressure, they can respond to light touch, but depending on what the pressure is, there will be a different response in the nervous system. And generally you can think of it in two different ways. Like the nervous system will either inhibit or relax, or it'll facilitate and guard, right? So and that response is dictated by the threat that's being imposed, right? So if the pain is great, it becomes more threatening. There's going to be more of the stimulatory guarded response to the tissue, and most likely it'll be worse the worse the threat is, right? So again, you can have these sort of responses of the nervous system to even something that's really intense, where like you feel like you move a little bit better afterwards, but you'll never get that secondary element of allowing the pressure that you're applying to your body to get deeper. And then with that depth, we can actually start to mobilize different parts of the anatomy. So I think that's really important there, is that we keep this idea of the threat as low as possible, but allow the tolerance to pressure to build over time. And that seems almost counterintuitive until you think about it. Like that's actually what we're doing with most training and most conditioning, right? If we're lifting a heavier weight, we're not starting with something that is really threatening to us. We're starting with something that we know we can do. It's not easy, but we know we can do it. And then we add a little bit more over time. But when our body is more tolerant to heavy weight because we've put the work in and we've trained it, that heavier weight doesn't feel as hard as it would have if we first started there, right? So we're always sort of like moving this tolerance. And as we're doing that, we're trying to keep the threat decently low in our training. So to me, this is just part of that therapeutic process of we're gradually adding pressure. We're gradually adding a stimulus that our body can then adapt to and get used to. And as it does that, it allows for more depth of pressure, right? So then those would be the first two Ds. Once we allow for more depth of pressure, so let's use the common psoas release that's so common now, that there's the pso-right, and there's all these different tools that are working on the psoas. The psoas is a deep hip flexor. It's also a lumbar muscle because it connects to most of the lumbar vertebrae. So we have to, in order to get anywhere near that, we have to go through the abdomen almost towards the back of the spine. So we have to get quite a bit of depth through the abdomen. Well, we're going through the abdominal muscles. We're working around the internal organs. There's going to be a ton of guarding there, right? If we want to have anything to do with getting in contact with that deep anatomy, we have to not allow the pressure to make us guard and block that depth. Once we get some depth there, then we can say, all right, let's say we're on that muscle, and now we want to create some motion of that muscle. So what does the hip flexor do? Well, it flexes the hip, but how do you stretch it? You extend the hip. So you can do something along the lines of active release, where you start to contract your muscle now into hip flexion while you have that depth of pressure there. And then you can also relax, let it get deeper, and then maybe go the other way, where you create a stretch by extending the hip in the opposite direction. So I would call that dissociation, where we have the pressure that's sort of blocking our lower back from extending, because you can't extend your spine when you have a pressure that's pushing from front to back if it's creating enough depth. So any motion that we now get from the hip should be a truer hip motion. So that's dissociating the hip action from the lumbar action, and we could say this with any joint. We're isolating more of that joint motion that we're trying to move from by blocking the compensation movement from the joint above it. So that would be dissociation. And then the fourth D would just be duration, which ties directly into desensitization and threat. So if a pressure in your body and you're able to keep that pressure there for longer, you're basically proving to your nervous system that's less of a threat than it thought it was. So a lot of times what you see is you initially apply pressure to an area of your body and the pain is greater at that moment because it's alarming. It's a threat at that moment. But then you breathe into it a little bit. You allow your body to relax into it. You spend more time, more duration on that pressure, and you're telling your body this is no longer a threat. By something being able to hang out in any situation for longer, it's not a threat, right? Because the threat response is all about impatience. It's about get the hell out of there, right? Like I'm about to die. I need to run away, right? It's something along those lines. That would be the kind of, the archetype of the fight or flight response is don't hang around, don't do something longer, get the hell out of there. So if you are able to spend more time into the pressure, you'll be able to go through all of these layers of desensitizing, allowing it to get deeper, and then you'll be able to add movement to it and dissociate.
Is there an archetype of a patient or a person that you'd use something specific with pressure therapy with, or does it just depend on the person? Because when I hear you talking in the language, I keep coming back to thinking about, like, there's a lot of similarities in language with an approach to treating chronic pain patients. And the idea of kind of gradual exposure to this threat, which in chronic pain patients might be the actual pain they're experiencing. And then this ability to sit with it and understand that maybe nothing actually needs to be done about the pain, and that you actually just need to try to find a way to relax into it to a certain extent, psychologically, or in this case with pressure therapy, physically. So is there a specific patient population you're more likely to use this with, or does it just vary person to person?
No, it really varies person to person because that's part of the therapeutic process. That like the word therapy to means it fits anyone's process. It's just the intensity that someone's able to tolerate will be a different starting point. Just like the weight someone's able to tolerate right off the get-go from strength training perspective will be different depending on someone's history, sensitivity, and their condition. So one of the things that I've definitely had to evolve over time is realizing what somebody's sensitivity might be. And it will be very different than my own. And it would be very different than maybe somebody that I just worked with, right? So I always err on the side of starting very easy for someone. If I get any type of reading that there could be an irritability to their symptoms. So for instance, if I'm thinking about putting pressure in someone's thoracic spine. So one of the things I like to do quite a bit, and we'll put videos to this stuff in the show notes, but is use a massage ball that's like a pinky ball, like an old school kind of soft ball that can smush a little bit, but right between the spine and the shoulder blade. So that would be like in the thoracic region, and then have people breathe into that, get heavy into that pressure, maybe move around it. But if I have someone do that in supine, that's a lot of pressure if you're not used to it right off the bat. And I've had some shocking experiences where just putting light pressure in the thoracic spine could create a lot of sympathetic symptoms, meaning like people get nauseous, people get dizzy, right? So it's just something like with experience I've learned over time, like don't be too aggressive, even if you don't think it's aggressive in that area. Like let somebody tell you that, yeah, that's not enough pressure before you assume that, just even supine is safe. So I'll usually have people start on walls or in a firm chair so that gravity is not pushing them into the pressure at first until they say, oh, that feels good, I want more pressure. Right. So that's a similar type of thought process of trying to figure out like what's the lighter load. Right. So with pressure, we're just thinking of it as, okay, how can we offload some of that discomfort, but still do the same thing. Right. And so you can do that by changing your relationship to gravity, or you can do that by softening the ball, the implement that you're using, or you can soften the surface. Right. So having somebody do a massage ball on a hard surface versus a bed, right? They're two different experiences. So maybe you have people start on a couple like really soft mats, right? So, and that's most gyms have different types of mats that you can use. Doing pressure work on a mat versus on a hard surface, two totally different experiences. But my previous experience in just noticing like the different communities that were using a lot of this pressure work, that just like never came into the discussion. It was always like you were talking about, it's just like make it hurt as much as possible, find the harder implement. I actually, like when I started working at as a coach for CrossFit, we had the exact same PVC pipes that you're describing, right? Like, and you know, in different communities that works fine until you have an injury that is really sensitive, and then you're actually start to make yourself worse with that, and then again, the thought process is, well, okay, this isn't useful, throw it out, as opposed to thinking like, can we just turn the volume down, or can we move around the area that's more sensitive instead of going right after the area that's sensitive? And this is where I think like the idea of getting lost in theories, like the more specific you make the theory, the less flexible the technique, right? So people were getting really specific with the theory. It's like, oh, it hurts here, so I have to roll this out because it's tight and I have to loosen it up, right? And it's just it's a specific theory, but it's like a really general, like weak theory of how the body works too, right? So actually thinking of it more from a systemic place, like where you're actually thinking about the whole system of the whole nervous system, the whole autonomic nervous system, like the fight or flight response, like oftentimes that's going to give you a better way to use the technique, where you're actually just you're trying to relax someone if they're in a state of sensitivity. You're trying to relax the whole body, so which means like you don't have to go anywhere near the area that is the most sensitive at that moment. You can actually work an area that's much less threatening to a person, but go through the same process of allowing them to feel more depth of pressure, right? Breathe into it, just allowing your body to get heavy on any pressure, even if it's distant from the area of injury, can calm down the whole system, which now makes the area that hurts hurt less, right? And I think that's something that also got lost in this attempt to just like make everything hurt as much as possible, or massage the thing that hurts as much as possible.
That's another theme for, in general, PT is sometimes looking elsewhere, well, and training, but just looking elsewhere if someone especially is really flared up. What are you looking at in terms of duration? Like how much time, how many days per week, or again, does it vary?
I mean, it varies, but I ideally I have like a goal of trying to get people to spend about 2 minutes on a pressure, but I won't throw them into that if I feel like I'm onboarding them to the process, right? Like the first time I introduce someone to pressure where I know it might be a little bit sensitive, I might just say like, all right, can you just do this for 30 seconds? Can you take like 2 good breaths on there, and then let's get up, let's talk about it, let's see how you do. Just because I'm very wary that the aftermath sometimes can be worse, you know, and I have to just assess that. And I also want to just show somebody that like we're in a process where I might tell someone like, I want you to eventually spend like a minute or two there. But if they hear that and they say like, that's impossible, I'm not going to say, no, it's not, like do 2 minutes right now, right? Like it's going to be like, all right, let's just do for like 15 seconds today. I just want to introduce you to this feeling. I want to like try to describe like why we're doing it. Like, so I'll go through like a mini spiel about like the idea of the body adapting to pressure and things like that, and how that could be very, very valuable and very direct for where they're feeling their symptoms. But I may be building the time up over time, so like I don't expect to get much of a therapeutic effect in like 15 to 30 seconds, but it is the start for somebody to be able to have like a practice that gives them a more direct effect over time.
We've talked a lot about like various types of, I guess, firm, or let's just say like a stationary pressure. Basically where I'm going with this is like, do you ever use the pressure therapy guns, like a Theragun or something like that with people? Because that's a different kind of stimulus, a little bit less purely sustained or static, and if so, how do you use it then?
Yeah, so I mean, first of all, like the vibration fits into the discussion of pressure mechanoreceptors, because it's just it's going to like if you threaten somebody with the vibration, right? Like if somebody is surprised by the vibration, or the vibration is greater than they were expecting, they can have the same response of being overstimulated and guard. And then that can make symptoms worse. Where if the pressure feels good, if it feels like it relaxes the area, and they can find the vibration that allows things to create more depth, it can have a similar effect. It's a little bit harder because the vibration is moving to create like a active movement on top of the pressure, but you could still do it. So in many ways, you can go through the exact same stages. Where I find a real benefit from the guns are with people that are like their function is low to the point where they can't really manipulate their body around a ball or around a foam roller, like actually propping up on their arms or even getting prone. It's too much. And they, in like being able to like put a ball and wedge it behind their back and even a wall, they can't get their arms there. Like they don't have the coordination to do it. But you could just get the gun, learn to turn it on, and like zap your areas. And I found that to be quite useful in many situations. And also just like for practical purposes, like when you find yourself sitting a lot, that you don't actually have to change your posture. Now, both of us want people to change their posture often, but we have to pick our battles and know like what's going to get people to do more things towards change. So instead of like fighting that battle of trying to force someone on the ground where they might actually not even be safe there, like it might be there's a reason that they're fearful of getting on the ground right now. Like we might have to be more gradual with that process. So getting them to have just more time where they're making themselves feel like they're relaxing tissue or just relaxing the nervous system as a whole, I find that the massage guns work quite well. Yeah, I used to use them quite a bit too, like almost as a manual therapy tool. Like when they first came in more vogue, like I was thinking along the same lines, is that I wanted to see if I could gradually get people to tolerate more pressure of the gun while they were just like lying on the table and having it be like a passive process. But I don't do as much work on people anymore, or I try to like teach them how to do it on themselves. But I think that's valid too.
No, it's interesting. Yeah, we don't have any of those at the clinic, but definitely we've had a lot of clients who come in with them or like say they have them, and kind of it's like, well, what have you been doing for an injury? And it's usually just like doing that and nothing else. So I think it's a good part of the process, but it's not the whole story or whole picture at all.
Yeah, absolutely. And I think it's still key is like whenever possible to try to connect any of those techniques to something else that somebody's complaining about, right? Like, so if it is more of like a relaxation thing, like it might be like after I have somebody do that, I'll just ask them like, how do you feel right now? Like, is there a positive response? It might not be connected to like a certain pain or movement, but it could just be like, how does your breathing feel right now? How does your, like anxiety that you just had feel? Like I've had some people recently where, with all the air smog that we've had and, just different allergies, that like sometimes we're just doing some pressure work just to bring awareness to the breathing anatomy. And it tends to slow people's respiration down. So after 2 minutes, people just will respond that, yeah, like I could breathe better now. Like I was breathing more up in my chest. Now I feel like my breath is a little bit lower down, right? So I might just get like a subjective response there. Or if there's a direct movement that somebody was having pain with, I'm definitely want to check that afterwards and just have some confirmation that, there was something that changed. Do you find that valuable, right? So this is a conversation to get some buy-in from your client, not just, what happened there. Oh yeah, like I stretched out your psoas or something like that. Like it never has to be that. It never has to be that specific. And when people try to make it that specific, I think that's where the controversy comes. It's just a piece. And I think the way, if you think about it, like we think about other things in the training process, like this adaptation process, like being able to tolerate more pressure usually indicates you're a more robust person. like in my experience, I'm sure your experience, right? Like, because what we're talking about, even like maybe the misuse of it with people in a weight room, like screaming and moaning, we're usually talking about pretty resilient, robust people, like athletes, or as you're getting more into a community where you're lifting heavier weights, like and like even these CrossFit communities, they might not be like athletes, but they're probably more robust and resilient than they were before they started that practice, right? So being able to tolerate more pressure is not a bad thing. It's just that like we're missing a lot of other things if we don't put it in this process of trying to gradually build more tolerance to things, because there's a difference between just like grinning and bearing and like screaming through pain and say, yeah, I could tolerate that, versus like, no, I can really tolerate that. Like I own that. I can have a conversation with you with this so right in my gut, right? Like I can control my breath. I feel it, but I can move around it, right? Like to me, that is more ownership of that pressure, right? You're not just surviving it. Like you're really kind of saying like, no, this is actually how you relax into pressure. And so there's a teaching process like everything else that I think is very worth going through.
Mm-hmm. Yeah, I couldn't agree more. I think the gradual part is the nature of this, and then all things physical therapy, training, and even some psychological things as well. That's potentially outside my scope to talk about, but
Yeah,
it's the process of adaptation of just like being a human or
absolutely.
a living organism.
And it's interesting you bring up psychology because yeah, it's outside of our scope, but I think I like in different research that I've done for terminology that we've got as like a core to our physical therapy practice, right? Like we've heard terms like adaptation, habituation, desensitization. These are all terms like within like specific conditions. Like I remember like desensitization was one of the things that we were supposed to try with people that had used to be called RSD. Now it's like complex regional pain syndrome, right? Like remember the little wands, right? The tactile ones, like you're supposed to basically be going from like rubbing cotton on the body to rubbing sandpaper on the body and see if the person can tolerate. Well, that's pressure therapy right there, right? Like that. But it was a very like gradual process, right? The wands had different numbers on them that was saying like, okay, if you're getting closer to sandpaper, you're like getting closer to, you could do like a 10. That's like sort of doing heavier weight, right, in the gym. But it wasn't very linear, right? Because but it was there, at least the mentality of there was you were being gradual with this process. And when you have conditions like a RSD or CRPS, it's really, really easy to like flare them up. But at least there's a therapeutic process there that's a little bit more objective, right? So I think that's useful. And then when you don't have that type of sensitive condition, right, it still makes a lot of sense to be in that process of being as gradual as process. But what I was alluding to there is like the terms like desensitization, habituation, they actually, a lot of them come from psychology, right? So when we're thinking about like having people get more habituated to behaviors, or if there's something that specifically like fears or phobias that people are anxious to, right, there's graded exposure to that. That's something we talk about a lot in physical therapy now, right? Is graded exposure to the thing. Well, like there's so much connection there. So yeah, it's not within our scope, but like a lot of times we're actually talking about the exact same tactics because the body is pretty connected, like in how it responds, no matter if we're working with the brain and behaviors, or if we're working with movement, or if we're working with pressure. There's a lot of the same themes that come up of how the body responds. So that's where, to me, like that's what therapy is. Therapy is this idea of just gradually adapting to things, but it's a process. It's not a single intervention, right? And that's what separates out a therapeutic process from pharmacy or surgery, right? It's you're doing something that you're going to gradually improve someone over time, and there's no reason that gradual improvement doesn't go beyond what their initial problem was. Like you can make them better than they were before by continuing to go through this process. And so that's where I think like therapy fits within this, and we're just using the thing that we're manipulating here just happens to be pressure.
Yeah, that was really well said.
Thank you. So the last thing I think to bring up here is like to what we talked about last week with the difference between stretching and mobility is I think this conversation about pressure sort of brings the stretching conversation full circle, because we mentioned different mechanoreceptors. Well, the idea of a stretch in the body from a very physiological standpoint is right there are stretch receptors, these muscle spindles within the body, right? So if we think about stretching in the same way that we're talking about pressure therapy right now, that is just a pressure being manipulated. It just happens to be a stretch pressure, right? So the same rules would apply though. So if you've ever been in a really, really intense position or a stretch position, so let's just say if anyone's ever done the couch stretch, for most people, where the shin is sort of vertical against the couch and you're trying to stretch out the front of your thigh, your hip flexor, or whatever you want to call it, that's usually really intense for people. But being there, you can kind of go through the similar process. Like initially, you don't try to move, you just try to like feel the discomfort, take a few breaths, see if that discomfort calms down. And once that calms down, now you can actually start to think about getting deeper into the stretch, right? Like you can go farther into the joint position that you're trying to move. So we're trying to go into hip extension while the knee is in flexion, which creates that's the most optimal stretch for the rectus femoris, which is the front of the thigh there. But depending on what we do with the pelvis, we're also stretching up into the higher hip flexors and things like that. But it's usually very intense. So we have to really first, before we try to move or do anything special there, we have to use the breath to calm ourselves down and desensitize us to that stretch. Then we go deeper into that stretch. And then from there, we can contract, relax. We can try to do movements in maybe other joints where we're dissociating some movements or actually creating a muscle contraction that strengthens the position. And then again, like spending time there will make that all better, right? Like we'll go through all that process. So stretching and pressure therapy, that to me, it's just like stretching is a different type of pressure that you're manipulating, but you would go through the same thing. And if you don't, right, like then you're not getting as much out of the stretching. That's where, again, you're going to just be left with this, yeah, I can feel a stretch, but I'm not changing anything. If you go through these 4 Ds, a lot of times you've just done a lot more with your stretch in 90 seconds, 2 minutes, and now you're starting to work towards joint mobility, which is what we were talking about last week.
Yeah, it gives you a different framework about which to go about it, which
Absolutely.
just changes the whole thing.
Absolutely. All right. Yeah, I figured that would be a complex discussion, but hopefully it was useful. I will definitely link videos in the show notes, because I've written 2 blogs on this, and I put this in my book because I did think it was something that was sort of like unique but valuable, because there was too many people like throwing out the baby with the bathwater, as a cliche to say, but like just they used to do foam rolling and all this, found it super valuable. Then there was some people that were saying, oh, it's not doing what you think it's doing, so it's like, okay, let's not do it at all. But there's still value there. We just have to think about things differently a lot of times.
Agreed.
All right, so next week, well, we'll chat next week about what we want to do, but I think we want to start to go into maybe some discussions about like specific movements, and also we can talk about specific injuries. We'll put our physical therapy hats on and
Cool.
talk about some clinical experience with specific injuries. So for the audience, send us any suggestions you might have, because at this point, that's what we're looking to try to direct it to the content of whoever's listening, and whatever you guys want us to talk about that's specific to maybe your case, and it can make for a great show.
Awesome. Sounds good.
I'll see you next week.
See you then.